First of all, I'd like to welcome you in our meeting, and I hope that you enjoy your stay in Jerba. So I will talk about the new algorithms to manage HF-pEF. And I will start with two daily clinical cases about two old patients. They have common cardiovascular risks such as chronic kidney disease, atrial fibrillation, but the first one, he has hypertension, he is obese, and the second one has carpal tunnel syndrome and lumbar spinal stenosis. So we should ask the question, do they have HF-pEF? To answer to this question, looking at the guidelines, it seemed to be easy to answer to this question. That means if we look to the guidelines, to have the diagnosis of HF-pEF, we should have symptoms or signs, ejection fraction 50% or above, and we should look for objective evidence that these symptoms and these signs come from the heart. And, for example, you should see if the left ventricle is a bit thick, if the left atrium is a bit large, and so on. But I think that you agree with me, in reality, it isn't easy to diagnose HF-pEF, because HF-pEF is a very heterogeneous entity, and signs and symptoms are non-specific. For example, if I have breathlessness when I climb stairs, and if I feel fatigue, is it due to HF-pEF? This is the question. So, there is another question also, what is the mean of preserved? You know that my normal ejection fraction may not be the same than yours. It's right, no? So, and you know also that ejection fraction vary, depends on the sex, depends on age, depends on ethnicity, and you know that women compared to men, given the age of the women, is higher than men. And this difference gets bigger and bigger where we go older. So this is very interesting, very important that you know that ejection fraction for women is higher than men. Patients with HF-pEF also have many significant comorbidities like hypertension, but the most common one is obesity. And you know that when we have a patient, obese patients, he can suffer from breathlessness, and we are not sure that it's due to HF-pEF. So we need many tests, many other tools, such as natriuretic peptides, but unfortunately, they are often also unreliable, especially in case of obesity. You know also, in obese patients, natriuretic peptides could be normal or low. So if we have normal or low natriuretic peptide in obese patients, it doesn't exclude HF-pEF. So it's very important to know. And I'm very happy to share with you this 2023 ACC expert consensus telling us about the diagnostic approach of HF-pEF as they recommend. And there are many steps to follow. Look, this is the first step. We have a patient with dyspnea and or edema. The first step is to assess the non-cardiac source. For example, if you have dyspnea, you should look if the dyspnea comes from the heart, or come from the lung, or come from other sources. The same thing for edema. Edema also can come from the heart, but also from the kidney, and also from the liver. And then, if you rule out all non-cardiac sources, you need to apply for the universal definition of heart failure. And it's based, as you see here, on symptoms and or signs. And for the first time, they mention natriuretic peptides, and you look here that the cutoffs differs for ambulatory and hospitalized patients. So here we can say that there is heart failure, but you should assess for heart failure mimics, especially non-cardiovascular mimics in congested patients, as I said, kidney disease, liver disease. After that, if you rule out non-cardiac mimics, you should also rule out HF-pEF mimics. That means heart failure attributed to a curable cardiac causes such as infiltrative cardiomyopathy, amyloidosis, hypertrophic cardiomyopathy, pericardial disease, for example, constrictive pericarditis, valvular heart disease. And the end, in this case, we'll say that it's a secondary HF-pEF, but it isn't the case. We will see that it is HF-pEF, but it will be HF-pEF associated with other comorbidities, hypertension, diabetes, renal kidney dysfunction, and coronary artery disease, and so on. So in this case, we say that it's a primary HF-pEF. So if we guess that it would be probably a HF-pEF, it's recommended to use a score, HF-pEF score, proposed by ECC consensus. H2 for heavy hypertension, F for atrial fibrillation, P for pulmonary hypertension, E for elderly, F for feeling the pressure on echocardiography. And if we have 6 or more score H2-F-pEF, it's very highly suggestive of HF-pEF. So we will say that it could be HF-pEF, high probability of HF-pEF. There are other scores, but we could discuss them after. Here I'd like to focus on this algorithm. It's very interesting in the case of intermediate patients, because you agree with me, in practice it is easy to conclude and to assess left ventricle filling pressure. We need many parameters to conclude. So I come back to our patient. We have same symptoms, echocardiographic parameters, and both with suggestive HF-pEF scores, but do they have PEF? I think that you agree. For me, for the first one, it's primary HF-pEF. The second one is a secondary HF-pEF, and we need further investigation to diagnose amyloidosis. So I arrived to the very interesting chapter. It's about the management of HF-pEF, the treatment of HF-pEF. As you know, the European guidelines, 2021, about heart failure was published before Emperor Preserved and Deliver. So we have in class 2 only diuretics and the management of comorbidities. But if we look to ACC 22, who are published after Emperor Preserved but before Deliver, we have a SGLT2 inhibitor in class 2A. And I like to share with you the very nice, wonderful flow chart, especially here this cute yellow diamond and with a green outline, anticipating the class 1 of SGLT2 inhibitor in the treatment of HF-pEF. So now we are very lucky. We have 2 great randomized clinical trials with their outcomes in HF-pEF. We have Emperor Preserved, we have Deliver, and so we have the publication of the new guidelines, European Society of Cardiology guidelines, a heart failure update, which were published recently in the last month. And you see here that SGLT2 inhibitor come to class 1 in the treatment of HF-pEF, and SGLT2 inhibitor, dapagliflozin or empagliflozin, are recommended in patients with HF-pEF to reduce risk of heart failure, hospitalization, and cardiovascular death. So my take-home message will based to this very interesting algorithm that I found interesting and wonderful. When you have a patient who is breathless, who has suffered from dyspnea, you should confirm the diagnosis of heart failure. I don't see ejection fraction, I see heart failure. And then you will give diuretics if there is congestion, and then you will get the ejection fraction if the ejection fraction is 50% or above. And if you exclude HF-pEF mimics, it will be HF-pEF and it will be primary HF-pEF. So you will start guideline-directed HF-pEF therapy as below, as you say. SGLT2 inhibitor for all the patients, diuretics if congestion, and as you say here, ARNI, MRA, if ejection fraction is up to 60%, especially for men. For women, we can give it. We can discuss this after. And then remember to treat the comorbidity. Comorbidity is very important, and I invite you to read this ECC consensus, but also another interesting paper about phenotypes of HF-pEF. We will give SGLT2 inhibitor, but we should give specific treatment for each phenotype and for each comorbidities. And I thank you for your attention.